with the hosting rights, do we do
Yes. Good morning. Good morning, everyone. It's my pleasure on behalf
Just
of
give
the
it sorry, Prof. Just give it a sec. The people are still
Oh, you
coming
haven't
in.
started yet?
Yeah.
Oh, okay.
Yeah, it started now, but the numbers are going up now as we speak.
So tell me when to start.
Yeah, go ahead, Prof.
Okay. Good afternoon, everyone. On behalf of the University of KwaZulu-Natal, I would like to welcome everyone to this special webinar session. This is part of a series of events that commemorate the World Kidney Month that started on the 10th of March, where we had our World Kidney Day, which is an international day that commemorates the kidney problems to be addressed worldwide. We put together an interesting program that will address the issue related to kidneys. I would like to share my screen now so that we can understand what we are talking about. Yes. So we think that it's very important to deal with the issue of preventions. The title is the preventions with an S of chronic kidney disease, just to highlight the spectrum of prevention that we have to deal with to address the chronic kidney disease we are faced with. So we have three speakers. The first one will be covering the primary prevention of chronic kidney disease, Dr. Sudesh Hariprasad. The second one will be covered by Dr. Denis. We will cover secondary prevention of chronic kidney disease. I, Alain Asunga, will cover the tertiary prevention of chronic kidney disease. We are from Nkosi Abel Central Hospital, Grace Hospital, and University of KwaZulu-Natal in Durban. So I would like to introduce each one of those when the times come. So I would like just to share a few data regarding epidemiology that everyone should be aware of. First of all, what are the causes of chronic kidney disease in KwaZulu-Natal? One should remember that there are three main causes of chronic kidney disease: hypertension, diabetes, and HIV. I know that being the epicenter of HIV disease, unfortunately, the kidney paying the price as well. So there is what is known as HIV-associated nephropathy, with the impact of large-scale ARV treatment. HIV patients are living longer. Now, in doing so, they're exposed to chronic kidney disease. Now, it's important that although we don't have the true prevalence, there are studies underway that trying to determine the true prevalence of chronic kidney disease in province. We can estimate that chronic kidney disease prevalence is about 13% of the population, which is similar to HIV prevalence, by the way. So if we accept that, that means that the estimate of chronic kidney disease at the last stage, which is stage 5, where the patient needs kidney replacement therapy, we will expect about 100 to 200 patients that will arrive at end stage, hence require kidney replacement therapy. We're talking about at least 1,000 new patients per year in KwaZulu-Natal alone, that we require dialysis or transplant, which is at least under 50 million per year. That's what we will require to be able to cope with the needs of patients in our province requiring dialysis. With that high cost, I think we should agree that we need prevention, prevention, and prevention. That's why we will be covering the three aspects of prevention as we indicated. So our program today will then cover primary prevention, as I indicated earlier. This slide summarizes the three types of prevention that we will be covering. Dr. Ripasar will cover the primary prevention, as you can see. The secondary prevention will be by Dr. Denis, and I will cover the tertiary prevention. That's from that slide. I would like to hand over now to Dr. Sudesh Haripasad. Just to introduce Dr. Sudesh Haripasad, is the head of the clinical unit of nephrology at Inkosi Albert Lutuli Central Hospital. His special interest is in the epidemiology of chronic kidney disease and big data. He is also an executive member of the South African Nephrology Society and a member of the International Society of Nephrology. His publication range from transplantation to COVID, vaccination, prevalence studies in adolescent hypertension, and use of estimate GFR, and co-author of the CKD in an African setting. With no further ado, I'm going to invite Dr. Haripasad to address the issue of primary prevention. Dr. Haripasad?
Thank you very much, Prof. I'd just like to share my screen.
Yeah, let me stop sharing so we can go ahead. You can go ahead.
Hey, thank you, Professor. Thanks to the organizers for the invitation. It's much appreciated. My topic, as Prof mentioned, is the primary prevention of chronic kidney disease. And just as a broad outline, I want to first of all establish a context. I think Prof provided some context, but look at CKD or chronic kidney disease worldwide and CKD in KwaZulu-Natal. Then we look at the need for primary prevention, and then look at what are the specifics of primary prevention, and then how to implement an effective primary prevention program in KZN. So chronic kidney disease, as by definition, is a functional or structural abnormality of the kidney. And in terms of chronicity, it has to be present for more than 3 months. In terms of the function, if you look at the filtration function of the kidney, it can be measured in terms of a test called the eGFR. In terms of the structure, we look at markers of kidney damage. That's in the form of blood or protein in the urine, which indicates that there's structural damage to the kidney. So CKD is regarded as a thief in the night. And we'll allude to that in future slides. But basically what it does is that it robs you of your health. And you don't even know that it's doing that. It's very common. It's harmful, especially if it's undiagnosed, undertreated. But it's very treatable, especially if you diagnose it early. So patients are not really sick, but they're not well either. So in terms of the context globally, there are about 700 million people worldwide with CKD. That's approximately 10% of the population. Unfortunately, most of them reside in developing countries. And it's predicted that more than 50% of the global disease burden will be due to non-communicable diseases in developing countries in the next 20 years. Therefore, it's the low middle income countries like ours who benefit the most if there is and there was appropriate intervention. So in terms of our national statistics, we have a South African Dialysis and Transplant Registry in 2017. And if you look at KZN, in terms of public dialysis, we've got 5, but we hopefully by 2022 moving up to 7 units. That's still far and away, far efficient than what we really need. Out of the 278 units for dialysis, most of them are in private. In terms of the amount of dialysis that we do provide, we provide 33 per million population in KwaZulu-Natal, which is far and away, far less. It's the 3rd lowest in the country. And the aim was to try and increase it at least 8-fold by 2025. So there's a lot of work that needs to be done to improve the amount of dialysis or the amount of renal replacement therapy that patients are getting. But if you look at the context of where we are, we did an audit of our wards, especially during the COVID period. If you look at our total referrals from January 2020 to November 2021, we referred 515 patients from 19 different hospitals. And this represented a 34 to 30 to 40% decrease in the total that we were used to. Most of these patients had chronic kidney failure and they required dialysis, and none were referred timeously for a proper workup or access. In other words, there was no primary or secondary prevention performed for the majority of these patients. And these numbers, even though they were reduced during COVID, far exceeds our current capacity. So in the context of all of this, it is an anomaly. We look at the best international trends. Patients who got end-stage kidney disease are followed up and managed and educated for a year or 6 months before they commence dialysis. The majority of our patients are crash landers. That means they present as an emergency. They present sometimes in severe distress, needing dialysis. And the primary and secondary prevention doesn't exist. They were just picked up as sick patients, found to have renal failure, and then referred to us. So you look at the risk factors, therefore, for chronic kidney disease. We looked at the ICD-10 codes from 2011 to 2019. Approximately 68.5% of our patients were hypertensive, 19% were diabetic, and HIV was 19.4%. So we have a combination not only of non-communicable disease, but we also have HIV that will add to the prevalence of chronic kidney disease. So look at the costs. I've updated the cost now from Prof. Sunga's slide for 2021. The cost per patient for dialysis per year, that's purely for kidney replacement therapy, is between 350 to 450,000. And that doesn't include the numerous acute admissions that the patients undergo as well. So it is an exorbitant cost. So therefore, there is a need for primary prevention. So what are we trying to do is increase dialysis, but we're certainly not going to increase it in any substantial way unless we look at why the tap is leaking, why it's open wide and it's flooding the floor. We need to look at the tap and try and close the tap. And that is with primary prevention. Now, there's international best practices with the International Society of Nephrology and KDIGO. They've looked at global best practices. They look at intervention and toolkits that we could use. And the aims, therefore, are to identify CKD by targeted screening based on known risk factors. We mentioned the risk factors that we have, followed by the risk stratification of these patients and treatment. And this has a potential to substantially reduce the morbidity and mortality, not only in our country, but other developing countries as well. So the aims of the ISN, therefore, are for the early detection and management to reduce the burden of CKD. It is especially relevant in socially disadvantaged and vulnerable populations because they carry a disproportionate burden of CKD and are less likely to be diagnosed early. So given the high healthcare costs of kidney failure, which I mentioned, especially in countries like ours, early screening offers economic benefits. And there are simple tests that they suggest that are not expensive, not invasive, and can be administered in a variety of settings. I have to reiterate that the screening is for high-risk individuals. It is not a mass general public screening. So look at targeted screening for high-risk groups in South Africa or in KZN. We look at people who have high blood pressure, diabetes, who have got HIV, who have an active urinary sediment. That means they have structural damage to the kidney. They have persistent blood or protein in their urine. They've got cardiovascular disease, they're obese, and they have a variety of autoimmune conditions, all of which makes them prone to chronic kidney disease. So the aim, therefore, is to determine the at-risk population individuals and to screen them for CKD. And the way they are screened is through measuring the kidney function and looking at the structure of the kidney. So the KDIGO has developed a heat map, and it's a useful tool in assessing the risk of kidney disease. They use very basic results. These include your filtration function, that is your estimated GFR, or glomerular filtration rate, and they look at albumin excretion, and it's measured by the albumin to creatinine ratio. And this is used to evaluate the risk of kidney disease progression as well as failure. So this is the heat map. This is what it looks like. On the vertical axis, it's graded from G1 to G5, which represents your filtration function of the kidney. And as you progress downwards, your kidney function reduces till it's less than 15 moles per minute, or if you can extrapolate it, less than 15% of what you would expect. That's when you need dialysis. On the horizontal axis, you look at the structural function of the kidney in terms of the amount of albumin we excrete. And the more albumin we excrete, the greater your structural damage. And there's a good color mapping over here, which shows whether the patient has got CKD, they need to be monitored, they need to be intensively managed, or they need to be referred. So this is already out there in the domain. It's available on the ISN website. It's ready for use. It's something which is very useful, especially to our clinicians. So as mentioned, the aim is to provide a diagnosis of CKD, identify those who are at high risk of CKD, and to refer those who are at very high risk of CKD. There's an algorithmic tree that they've developed as well. As I mentioned, there's risk factors that you can look for. You screen the patient by doing basic tests. You measure the kidney function and determine if they have CKD, and then you implement lifestyle modification if they are CKD patients, and medical treatment, appropriate medical treatment. So this is an algorithm that can be used in virtually any clinic in any setting in our province. Looking at the costs, now urine dipsticks, the cost is negligible in the public service. Doing a blood pressure is negligible. A glucometer reading is also negligible. Measuring height and weight is the same. The cost of a urea and electrolytes with an estimated GFR is about 95 Rand. And measuring the urinary albumin to creatinine ratio is about 82 Rand 50. So if you look at the context of the cost of dialysis, as opposed to trying to find somebody with kidney disease and manage them early enough, there's a huge potential benefit. Now, there are certain modifiable lifestyle factors for primary prevention of CKD. So it's not possible to subject lifestyle modification or lifestyle factors to clinical trials. A systematic review and meta-analysis was done, and it looked at different factors that could try to reduce your risk of CKD. And it's similar to any other non-communicable disease. The factors that were found to be of value or reduce the odds of CKD are vegetarian diet, increasing your physical activity, and limiting the amount of alcohol as well as tobacco. So what is required then is an enhanced collaboration between your primary care physicians and nephrology. Primary care is essential for screening for CKD, and in the early stages, they can be managed by the primary care physicians. This includes the screening, the management, as well as the referral. There aren't enough nephrologists in the world, and we have to develop a sustainable collaboration with all levels of care for this to be implemented. It has to be an integrated management. That is, we have to manage non-communicable diseases. This is the new wave. This is the new silent pandemic with HIV in an integrated manner. And it's recommend that you use appropriate algorithmic tools to identify as well as manage non-communicable diseases and HIV together. So my final slide, therefore, is that information is not knowledge. It has to be passed down. It has to be properly done. And what we've tried to do now is try to interact with our clinicians out there through the use of the Bola app that's been introduced to us, try to communicate with them effectively, to collaborate with them, and to integrate the management. Importantly, we need health literacy for patients, that the information we provide for their health has to be culture specific and easily understandable. One of the important things that needs to be developed is CKD registry for planning of kidney care in KZN. So I'd like to thank you very much for your time. Thank you, Prof.
Thank you, Dr. Hariprasad, for that excellent presentation to set the scene of the preventions. So I'm going to hand over to Dr. Adeni, who will be presenting on the secondary prevention. Dr. Adeni is a head of clinical unit, nephrology, honorary lecturer, and in internal medicine at UKZN. He has MBBS, FW, SCP, and FCP from South Africa. He's a certificate of nephrology for the College of Medicine and MedSci for clinical epidemiology for Stellenbosch. His research interest is on understanding the risk and preventing progression of chronic kidney disease and improving outcome of CKD patients who are on renal replacement therapy or not yet dependent on renal replacement therapy. With no further ado, I would like to ask Dr. Denis to go ahead with his presentation. Thank you. Dr. Denis, you can go ahead.
Doctor, you're muted.
Okay, I'll be set to go now. Can you perhaps see my screen?
Yes, we do.
Okay. Good afternoon, everybody. My name is Dr. Adeni. I work at Grace Hospital, and I'll be talking about the secondary prevention of CKD progression. I would try to look at it in a more systems-based kind of approach. And to start with, secondary prevention of CKD just means picking up CKD at a very early stage and trying to do things that can help to prevent progression to end-stage kidney disease. That is when most patients may not know that they've got kidney disease. So my outline is in this. I'm aiming to try and go through these subheadings. So I'll go through introduction and background, contributing factors to CKD, and what can be done. So as an introductory opening, Dr. Aripasad has rightly defined what CKD means. And my slide was just to try and emphasize that. And the thing about CKD is, like he also emphasized, is can be very silent until very late in the disease. And majority of people who don't know that they've got kidney disease. So identifying the risk factors and causes is crucial to a successful management. So worldwide, it's an increasing global problem. And it's now one of the leading causes of mortality. I think it's ranked number 17. And it has a high cost burden on societies. So its prevalence is put at 7 to 12%, depending on which area of the world you are. In some countries, as high as 16%. And then it also varies according to disease condition or risk factors the patient may have. For instance, a diabetic may have a risk as high as 40%. And then the age of the population also contributes to that. So the key problem with it is the fact that most of our patients tend to present very late. And this late presentation and diagnosis kind of escalate the cost. And so the late presentation can be due to so many factors, from a lack of awareness about CKD to systems failure, where patients are not picked up early, they are not referred early, and then they miss, or where it is diagnosed, they may not have been treated appropriately. Then there is the cost and accessibility then just keeps rising and rising. And if you look across the world, the accessibility, the cost and affordability of managing CKD patients is not equal across the world. And even if we take an average, not every country is resourced equally to be able to deal with it. And it's more so for low-income countries and middle-income countries, which we kind of fall into. And therefore, in order to avoid having to bear this burden of costs, we have to try to diagnose early. You have seen this previously, so I won't dwell so much on it. The aim of it is that we just want to try and pick up patients before they get to G5, so that we can avoid the costs that is thereof. And orange to red area is when you really need to start referring patients down to a nephrologist, while the screening part will be the green and the yellow. Now, this is a survey that was done in 2017, and it was looking at prevalence of renal replacement therapy across the world. Not every country responded, but of the countries that responded, you could see the red, the orange, and the yellow indicates the countries that tend to do more dialysis. Fortunately, South Africa falls into the yellow range if you look down there. But the majority of African countries does not have enough to be able to deal with it. And there are some missing data. So in other words, the costs will be a major driver for this kind of distribution. Because if you look very closely, to be the more developed countries that tend to dialyze the more. Now, nobody is really effectively free from being at risk of CKD. If you look at it very well, the contributing factors can range from while in the uterus down to old age, and different factors come into play. So coded in orange will be environmental factors, which runs across board, whichever age one belongs to. In some cases, genetics plays a role, and then the systemic illnesses. Now, this conceptual map is a way nephrology world is kind of looking at kidney failure currently. And it's trying to attest to the fact that before the kidney fails, ultimately, there is a risk. Individuals involved will be at a higher risk. And then they will progress on to damage if the risk was not controlled. And then the GFR then gradually falls before they then go into kidney failure. And we are trying to prevent them from dying. Now, if you look in the middle, preventing progression and complication of CKD falls under secondary prevention. So what can we do to try and effectively manage this? Dr. Aripasad mentioned about screening, and worldwide, there are two approaches, or actually three approaches to screening. So two large groups, population-based screening and also opportunistic screening. The population-based screening is where you just gather a group of people, you go to the school, or church or something, or the whole of the province, and start screening them. They've shown that that is not cost-effective. Which is why it is more important to aim for targeted population screening. And examples of those were those Dr. Aripasad mentioned, and some of them are also here. And then you have opportunistic screening, where you adopt a method where you hook on CKD screening to doing when a patient presents for other reasons. For instance, they come in for antenatal care and you hook on CKD screening to it. They come in for HIV screening, you hook on CKD screening to it. So this is easily achievable in our population, and so should be encouraged. So we should then aim to adopt cost-effective modalities and then use CKD and incorporate CKD screening into both NCD and infectious diseases clinics, targeting specific population groups. And that way we would be able to catch the majority of the people who are at risk. And then we increase their awareness. Now to early detection, this speaks to being aware of the fact that some of the best ways to monitor and pick up early kidney damage are very simple. Example is just simply measuring the blood pressure, checking the protein in urine by urine examination, and also trying to quantify. And it's also being advised that you should try to use EGFR estimated GFR as much as possible, because the relationship of creatinine is not linear to the GFR. So in early stages of CKD, there might not be significant increments in creatinine level, yet there is a significant decline in the GFR. So trying to use estimated GFR as a marker could be a very important thing to do. So if we are able to do those, then we would probably pick up a lot more. And then the patient then gets referred to a specialist center where they should then be evaluated appropriately, and decisions are made on imaging, kidney biopsies, and measuring other biomarkers that might help to reveal the disease much earlier. So like genetic studies in ADPKD, for instance, can be an example. So some of the markers are not fully available for clinical practice as of yet, or they are available in the developed world. But at least we should try and do as much as we can based on what we have available. So to be able to achieve this, we should try to aim to empower medical personnel and staff by training them so that they recognize this detection modalities that are available to us, and then equipping various levels of care to be able to carry out this diagnostic workup. And to be able to train them well and teach them to be able to use this very well, we will need to develop SOPs and protocols of care that can then be distributed to these various clinic levels and used in training doctors to be able to use. And then we also need to audit and see what we're achieving as we go along the way. Now, for effective referral of patients, we need to establish very clear-cut referral pathways and find ways to make it easy for physicians or doctors to refer from every level of care so that patients can get to the necessary level early. And also to be able to feed back to these doctors so that they know exactly what it has led to and how to improve on what has been done. So hopefully this might help to increase early detection and diagnosis. Now, once they are now detected, the way to now go is to try to give interventions that have been proven to slow down progression of kidney disease. So simple things should not be forgotten, although they may seem like they are preventive, but actually they also contribute to delaying progression of kidney disease. For instance, simple things as controlling salt intake can reduce fluid retention in a patient, which can end up being toxic to the patient and cause more cardiac damage. Giving them appropriate protein intake, as much as high protein intake can worsen renal progression, you also don't want to give them too little such that they then become malnourished. So, and a large proportion of our patient population are quite malnourished. Fruits and vegetables are a bit of a catch-22 because they give things you don't want, like potassium and phosphorus. But sometimes, because they also contain alkali, which has been shown to reduce or provide citrates to them, which might actually reduce renal fibrosis and progression of kidney damage. So again, one needs to wait properly and see who can tolerate the fruit so that we don't deny them the opportunity. Now, of all the risk factors, hypertension control is very crucial. Irrespective of what agent is used, it's very important to try and get down the blood pressure. Now, beyond the blood pressure control, using specific agents can now increase the benefits you get from the control. But the first aim is to try and control this blood pressure appropriately. Example of agents that can help is ACE inhibitors and ARBs. Then glycemic control is very important in diabetic patients. because progression of target organs in diabetes is affected by the level of glucose and the glycation products that tend to form in the process. So it's quite important to try and control the sugar very well. I've adduced to acidosis control, which can be both dietary and use of medical. I've been encouraging my unit to make use of Shaw solution, for instance, which has less sodium than sodium bicarb. Sodium bicarb has more sodium, and patients who cannot tolerate so much sodium, maybe because of blood pressure or fluid retention, might tolerate that a bit better. And it tends to provide some alkali, which can neutralize some of the acid that tends to come up as the kidney disease progresses. Then effective treatment of non-risk factors. So Dr. Aripasad also adduced this, encouraging them to weight control, to exercise, adopting good lifestyle, cutting back on smoking, stopping smoking and cutting back on alcohol intake, and then effective management of acute kidney injury. In the past, we used to think acute kidney injury is just a once-off event. That is, if you have AKI and you recover, that's the end of the story. But a large population of patients with acute kidney injury are now progressing to CKD. So it's becoming a very, very important cause of CKD, which needs to be tackled. So the advice now is don't hands off after managing the patient for acute kidney injury. You still need to follow them up, ensure one, full recovery from the AKI. If they've not recovered fully, then you need to monitor them and continue follow at least on a yearly basis so that you can limit progression of kidney disease. And then I've mentioned about ACE inhibitors. And then amongst the medications that are now newly found to be useful in diabetes, type 2 diabetes, SGLT2 inhibitors. And they've been shown to actually limit progression of CKD in addition to helping to control blood sugar. In fact, it's been found to be poorer as a blood glucose control agent, but more effective as a cardiovascular risk treatment agent and also prevention of progression of CKD. So there are trials that have been shown that you can even use them in non-diabetics because they are not very effective as an anti-diabetic agent. They don't bring down blood glucose that well. So that's an example of an agent that you can use specifically that can target certain types of disease. And then if we talk about ADPKD, there are other agents, that's autosomal dominant polycystic kidney disease. There are other agents that can potentially be used. Thank you. That will be the end of my presentation. Thank you very much.
Thank you, Dr. Adeni, for that excellent overview of the secondary prevention. So I'm going to continue with the tertiary prevention side. I'm going to share my slides. Thank you. Now we just covered the two parts, primary prevention and secondary prevention. The tertiary prevention is one thing that many people are aware of. Unfortunately, when people talk about the kidney program, they more concentrate in tertiary treatment or tertiary prevention. Can you see me now? One second. So I'm going to cover tertiary prevention of chronic kidney disease. Starting with this outline, we want to prevent CKD progression, complications to be prevented, as well as premature death. So one could wonder, say, why talking about prevention where someone is already on dialysis? I think it's a fair question. In fact, you have to continue preventing because you want to make sure that your patient does end up having complications of chronic kidney disease and premature death because the dialysis was not handled properly. So very important to bear that in mind. So we will have to look at the kidney replacement treatment part of the CKD prevention. And we'll conclude with supportive care. Now, I showed this slide earlier, and talk about tertiary prevention will be what I'm going to cover just now.
Sorry, Prof, we can't see your screen.
Sorry. Can you see it now?
No, not Prof.
Not yet.
Just share screen.
Okay, let's see. Let me try again. Hello? Hello?
Hello, Prof.
Prof, you seem to be on mute.
Can you?
We can hear you now.
Oh, can we hear now? Okay, I have to go out and. Can you hear me now?
Yes, we can, Prof.
Okay, let me go back here. Sorry. Can you hear me now?
Yes, we can, and we can see your slides.
All right, that's fine. Sorry about that technical glitch. Now, I was saying that we need to prevent CKD prevention in a way that we should avoid complication and premature death. So we will need to, we need to, first of all, to avoid nephrotoxins like non-steroidal anti-inflammatory drugs that we use when we are pain. You have to avoid herbal toxins like Impilo. I know that the use of Voltaren, Dometacin, and ibuprofen can then affect the kidney and then may destroy the kidney, which is already sick. The second point is use of AC inhibitors that Dr. Denis just mentioned is very important because it protects the kidney. It reduces protein, because proteins are toxic to the kidney cells. If you are high protein in your urine, it's very dangerous going forward. It will destroy your kidney quickly. Now, we need also to adopt the measures that reduce cardiovascular disease. It's important to do so because if you don't look after the cardiovascular disease risk, like lipid management and smoking cessation, you will end up losing your kidney function quicker or dying for cardiovascular disease. So it's important to adopt those measures. Now, as I said, my role is to look at the treatment, appropriate treatment of end-stage kidney disease, meaning that we need to look after complication of kidney disease and reduce that complication, which is hypertension. It's important to adopt a low salt intake, because if you keep high salt, you then retain fluid, and that will worsen your kidney function, your hypertension. As I say, EC inhibitor is very important choice. Calcium channel blockers are another group of drugs that will help reduce blood pressure. Using diuretics and vasodilators are important. The next complication you want to avoid is anemia. Because the kidney is responsible for production of a hormone called erythropoietin that will make your bone marrow produce red blood cells. If you don't bring erythropoietin on board at this stage, you become anemic. The third complication is mineral bone disease. And what's happened is that there are a way of preventing mineral bone disease to appropriate treatment of what's called phosphate binders. I know that many patients don't like it because they don't taste good, but it's important to prevent phosphate from being absorbed. You have to take those drugs in the middle of the meal so that you block phosphate to be absorbed into your body. So that's important treatment to prevent the bone disease related to kidney disease. Of course, you have to take vitamin D because your kidney being not able to produce vitamin D, you become vitamin D deficient. So that's very important. We talked about fluid restriction is an important part of the treatment. And so that you need to prevent edema, the swelling of your body, and eventually heart failure and difficulty in breathing. The next complication that you have to prevent is acid-base and electrolyte abnormalities. That's very, very important complication. You have to make sure that when we dialyze you sometimes before dialysis, we remember that Dr. Denis mentioned the short solution to reduce acid content in your system. So it's important that those are the treatment that you may have to resort to before you reach dialysis. The one which is very important, which is maybe responsible for killing patients, is potassium. And it's sometimes very, very tempting because you have so many good fruits that you are tempted to eat, bananas, grapes and so on, contain a lot of potassium. Yes, if you don't pay attention to potassium, it may end up causing arrhythmia and then having cardiac arrest. So the nutritional measures are important. You have to be aware of that. Adaptive protein intake is important so that you can avoid those complications related to poor nutrition. Now, the third complication group we have to make sure is that we have to make sure that we produce supportive care in order to control the pain, so control the symptom, and psychosocial support is very important. So those are the non-dialysis dependent or treatment that you have to entertain. So what is usually known when people, the patient reach end stage is dialysis, is the kidney replacement therapy. So it's important to realize that to manage dialysis, we need a multidisciplinary team. We need nurses, doctors, clinical technologists, dietitians, social workers, and psychologists. So it's important that that team be led by nephrologists who have spent a lot of time managing those patients, learning how to manage those patients to avoid so many complications, to lead that team effectively. Because one needs to know that among the 3 types of kidney replacement therapies, the first one is kidney transplantation, because it's the best form of kidney replacement therapy. It requires compatible kidney and requires immunosuppression. So we need to make sure that whenever someone arrives at stage 5, which is end-stage kidney disease, the first choice will be to go for kidney transplantation if possible, if he is suitable for that as well. The next type of treatment is called peritoneal dialysis. It's very suitable for as a home-based care treatment. And as you can see, there's a summary here that shows that it's simplicity that you have to produce exchanges 4 times a day of a certain volume of fluid that will go into your body and be participating in exchanges, removing the toxins and be removed. And by repeating the 4 times a day, you keep your body clean and your toxin as low as possible. It's easy to use in the resource-limited area, but the risk of infection, if not done properly, you have to follow the rules that are required. The last is hemodialysis type of treatment. In this case, what you have, you have blood that need to go out and go into hemodialysis machine. It's a circuit where through the hemodialysis, there's an exchange that takes place where the toxins are removed and will be then taken up in the dialysis fluid, and the clean blood will be returned to you. And it may take up to 4 hours for you to maintain your body relatively clean in this session, about every other day. But you require to have a good infrastructure, machinery, electricity. You have required to have a good access, but the advantage that it removes the toxin rather quite quickly. So this is what we showed earlier to summarize the 3 steps of prevention: the primary, the secondary, and the tertiary. So I'm going to share this slide, which indicate that we talk about supportive care. It actually need to be a continuum from the time you have chronic kidney disease and all the way to the end stage. So we need to provide support to the patient so that it will be able to cope with the disease as indicated earlier. So I would like to share this the reference that we have that you produced about 10 years ago, but it's still relevant, so that you can have further input to help you cope with any problem that you don't understand. Thank you for your attention. So let me open the floor for discussion. Maybe I'm going to go straight to the chat. Okay, I think question answered the way. Okay, let me start with the first question by Hari Ramnaran, who asks, should women with preeclampsia or proteinuria in pregnancy be considered high risk for CKD? May I ask Dr. Denis to address this question? This was part of his topic, or Dr. Aripasad?
Prof, I'll be happy to, if you want.
Okay.
Thank you very much, Harry. I think for proteinuria, or albuminuria, it suggests that there's damage to the kidney, as mentioned, that there's structural damage. Now, pregnancy itself is associated with physiological marker proteinuria. And the only way we can determine how severe it is an increase if you measure it, and there's a significant increase and it stays increased. But one of the definitive factors is that once pregnancy is over and if your proteinuria persists, then that itself is a high risk factor for CKD, especially if it's more than 3 months. And there's a second question, Doc. Not sure if you want me to.
Yes. Okay.
The second question is about obesity, independent risk factor for CKD. Now, what we found over the past few years is that there's a growing number of obese patients, typically morbidly obese patients. And we find that there's an entity called obesity-related glomerulopathy. And these patients actually come in sometimes with renal failure. It's very heartbreaking because we can't offer them dialysis. So certainly it is an independent risk factor for CKD. It has become, and there's a clear association now with hypertension and diabetes as well. So you must remember that kidney disease doesn't necessarily mean there's one cause. It's generally multifactorial. Thanks, Bob.
Okay, thank you for those answers. And if there are more questions, please post them or request.
May I also add, if you don't mind?
Yes. Yes.
I just want to say that taking a history about hypertension in pregnancy, preeclampsia in previous pregnancies is a very, very sensitive screening to do on a woman, because I found that majority of patients will have previous history of hypertension and or preeclampsia in previous pregnancy. And studies have shown that preeclampsia is a testimony to the fact that the patient has abnormal endothelium, which doesn't go away. And so it predicts hypertension in the future. It predicts cardiovascular disease risk in the future. And it predicts the risk of CKD in the future. So again, patients with preeclampsia should not be treated and left alone. They need to be followed up at intervals.
Yes, thank you. Any other questions? Yeah, then talk about obesity, it's important that losing weight, excess weight is very important to make sure that you become fit and be able to allow your kidney to perform better and other organs as well, the heart and so on. It's important that especially central obesity need to be avoided. Okay. Then one more question I want to read here. Is there any local experience with the use of GLP receptor agonists and prevention of progression to CKD in diabetics? So that's let's ask Dr. Denis and who is
Yes.
that part of the.
Thank you very much. Thanks for the question. GLP receptor antagonist is one of the newer agents that has been found to be very useful. Before now, for type 2 diabetics, we only had metformin, which has not been very effective at preventing progression of kidney disease. Now, with the newer agents, example being SGLT2 inhibitor and GLP-1 receptor agonists, we found newer agents, almost like a quantum leap currently, that can potentially, in addition to controlling blood sugar, can actually limit progression of CKD. In terms of personal experience, I've not had personal experience using them. I know there's an agent called Sinjadi that is empagliflozin. It's a type of SGLT2 inhibitor that is now currently available. And I'm sure there will be other ones, but in the state sector, we don't have access to them. It would mostly be available in private. And so personally, I've not had experience using it. But the literature shows that both SGLT2 inhibitor and secondly, GLP-1 receptor agonists can limit progression of CKD. Another agent that has been newly discovered is also in the group of mineralocorticoid receptor antagonists. An example would be finerenone, which is a non-steroidal mineralocorticoid receptor antagonist. It's also been shown to reduce progression of CKD, both in diabetic and non-diabetic kidney disease. So they are, when they do become available, they should be major agents that we should be using early in the disease, because the benefit is more if we use them early so that we can prevent progression than to wait until the patient gets to end stage. Thank you.
Okay. Just a comment regarding prevention, progression of CKD. One area with simple area that we sometimes overlook is the control of uric acid. It's now one of the factors that lead to progression. So for any patient who have high uric acid need to be controlled so that we can protect the kidney further. So that's what I want to add. There's a question regarding how soon, from Prim Naidu, how soon can you take a second dose of antibiotic for UTI if your kidney side pain persists? Want to address it?
Prof, I'd be happy to do that.
Okay.
I think if the first dose has generally failed, it's best to seek some medical intervention, because if you've got kidney or side pain, it suggests that there's infection of the kidney, and that would require intravenous antibiotics. So that's quite something that needs to be taken quite seriously as well.
Yes. Yeah, I agree. So what is important here to determine what is responsible for UTI? So the urine culture is very important to determine which type of microbe you are dealing with, and then treat it appropriately. And the treatment for a kidney infection is minimum 2 weeks, 14 days. I know that sometimes the treatment is shortened, and hence we have a recurrence of the disease. So it's important to make sure that it's treated for 14 days to be able to control the infection. And after each treatment, you have to do a urine checkup so that you make sure that your treatment resolve the problem. Because you may have a selection of another microorganism that was suppressed, and now that the main microorganism is destroyed, you may now see another infection coming up. So it's important to have a follow-up urine culture so that make sure that your treatment has been effective. Any other questions, comments?
Prof, can I also add that the type of agent also being used is also important because use of aminoglycosides needs to be carefully used and monitored. Otherwise, repeating them and prolonging the therapy when it's not necessary can be very, very toxic to the kidney. And avoiding multiple dosing of aminoglycoside is also very crucial because aminoglycosides killed by their high dose their maximum level. So, and not by maintaining a high trough. So you want to achieve discrete peaks, and rather than maintaining a steady level in the blood. Because if you do that, then you will be encouraging more toxicity to happen to the kidney. So the kind of antibiotic used is also very important. Some of them will cause acute interstitial nephritis also.
Yes. Now that's important. Any nephrotoxins, it should be avoided at all costs if you are not able to control it, unless you can measure the blood level, which is always difficult. So we should choose the non-nephrotoxic antibiotics as much as possible. So there's another question from Ari Ramnaren. As nephrologists, would you advocate the starting of EC inhibitor in all newly diagnosed type 2 diabetic, irrespective of the presence of hypertension for renal and the CVS protection? Want to address it?
Yes. If I may go ahead to do it.
Yes, go ahead.
I would say one needs to be careful in the sense that drugs are also toxins, depending on how well you use them. One needs to be careful in the use. In a patient who is not hypertensive, you will be subjecting them to the risk of hypotension. But if you monitor them closely and there's microalbuminuria, then the chances that it will be beneficial to the patient is high. So that's when you measure albumin-creatinine ratio, and it's between 30 to 300 milligrams per millimole, or per gram, sorry. And if you convert that to our unit, which is in grams per millimole, we're saying 0.03 to 0.3. 0.003 to 0.03. That will come to 300 milligrams. So if you could pick a patient with elevated albumin but not significantly high, then you could use that as a discriminatory tool to know when to start an ACE inhibitor. But to use it in a patient who is not hypertensive might be a bit tricky. There may be benefit, but you might also subject them to hypotension, and that alone is enough to also cause ischemia to the kidney.
Yeah. Now it depends on the proteinuria. So it's very effective to control protein by using ACE inhibition. Now one has to always ensure that the side effects, like as I say, the blood pressure being low, and also hyperkalemia. So you have to, according to the two. So maintain a good pressure. Usually it's good to start with very low dose if you're having proteinuria, and then titrate it accordingly. So by doing so, you'll be able to control your proteinuria, because what's happened is the protein is tubulotoxic. When you have proteinuria, it will destroy your proximal tubules cells. So the higher the protein, the more dangerous the impact on the kidney. That's why if you say diabetic, as soon as diabetic reaches nephrotic range proteinuria, more than 3 grams, it goes downhill. You would expect within 6 months or so, the kidney function will deteriorate. So you have to make sure that the proteinuria is controlled. Yes, you have to ensure that the blood pressure is not too low and the potassium not too high. Thank you. Any other questions?
There are other questions, Prof, on the chat box.
Okay, let me open the chat. See. Okay, there's one question here. Maybe let's see. I read them randomly. From the rheumatological aspect, the treatment of asymptomatic hyperuricemia is not recommended. Furthermore, CKD is a risk factor for allopurinol or risk side effect. How do you recommend that uric acid is managed? So maybe I should comment on this as I raised it. It's clear now that uricemia, hyperuricemia is a risk factor for deterioration of kidney function. Yes, in patients who have deteriorated kidney function, they will benefit. Now, the levels it's not clear what is the targets, and we look at it in our series as well. Allopurinol is a risk. You have to make sure that because of the risk of bone marrow suppression that may occur, especially if your patient is also using other immunosuppressive agent, then it will be important that you avoid allopurinol if there's side effects. But it's always risk-benefit. If especially those are high uric acid, you will benefit for reducing that load. That not clear what's the level at the moment. That will be a target level. But a high uric acid, yes, we need to bring it down. You will protect your kidney further. Any other comments?
Prof, may I say that also there is a study looking at febuxostat, which is another type of anti-hyperuricemic agent, and the benefit of using it was not very clear in the study, and so the jury is still out, and that's why it's not yet in full recommendation that it should be used across board. But the earlier studies in certain groups of patients, especially in the young hypertensive who also have hyperuricemia, it was shown to retard progression of CKD. So it's still a bit of an equipoise, and so it looks like we might need to select carefully what group of patients that would benefit from it and what group of patients may not benefit from it. And I think it will need to be done. There will be a need to do a bigger study to be 100% certain.
Okay. Any other comments?
Yes, Prof. Just to mention that the dose of allopurinol, even if it's hyperuricemia, should be reduced in anybody with CKD or with who's at risk for CKD. I think we generally drop it to 100 milligrams if we are going to use it.
Okay, there are more questions here. Let me go to the chat. So SM, so how much understanding do we have in the region, SADC and Africa, concerning CKD and chronic kidney disease of a known etiology? Are we managing these two the same way? Want to address it?
Yes, CKD-U depends on the region that is involved and the risk factors that are identified. So CKD-U can be hereditary partly and can be environmentally induced. In certain population has been described amongst agricultural workers, sugarcane farmers. And we do have a lot of sugarcane here. I don't know the experience in Durban, but we are yet to, at least as far as I know, we don't have studies from within that has looked at this properly. But many of our CKD patients have causes that are yet to be identified, because by the time they get to us, their kidney sizes are small, so we're unable to do a kidney biopsy. What proportion of those may be of unusual etiology, we don't know for sure. But the risk factors that are largely identified are usually diabetes, hypertension, HIV, and glomerulonephritis. But my summation is that I'm not aware of any study looking at CKD-U that is unknown etiology that might have some background hereditary predisposition and exposure to certain chemicals or agricultural products.
That's correct. I agree. Okay, let's move on to the next question that I can see here. Sorry. Now, this is question for SP. Good afternoon, everyone. My name is Simon Platier, a nurse from at peritoneal dialysis ward. I just want to ask about the patient who is diabetic based and using 1.5% Daniel bag. Isn't the glucose elevated glucose level to patients? So we want to address the question.
I can also do so, Prof.
Okay.
Yeah. Yes, it's a potential risk because some of the glucose would be absorbed by the patient, and but because of the time, the duration of time we tend to keep the fluid in, a large percentage of the glucose is not absorbed, and so its ability to then take out fluid from the patient. The dextrose is being used as an osmotic agent, which then draws water out of the patient. So it's not an ideal osmotic agent because a fraction of it will be absorbed, and so may potentially increase glucose level. But it's been studied and it's been shown that all it then leads to is you might need to then adjust the dosage of your anti-diabetic agents that you're using, especially insulin, and may contribute to weight gain in the patient. So ultimately, it doesn't have major impact in terms of long-term outcome, because by the time a patient gets to end-stage kidney disease and has target organ damage, tight glycemic control is not so crucial anymore because the organs you're trying to protect are already damaged. So instead, you'll be increasing the risk of hypoglycemia in this patient. So using a dextrose-based osmotic agent, yes, would increase the glucose level, but it might be a protection against hypoglycemia, 1. 2, all you would need to do is adjust your anti-diabetic agents. And there are also other biocompatible fluids that can be used that will not have so much impact on glucose. For instance, using extranil, which is a polymer of dextrose and doesn't get absorbed that much. Although if you use certain types of strips, it might affect your results, and you may misinterpret it as being too much glucose in the blood, but actually it doesn't get absorbed because of that. And then there are things like amino acids, and then there are a few other agents that are being tried because glucose is actually, dextrose is actually toxic to the peritoneum. And so we want to use the weakest bag possible in a patient to achieve our goal. So the answer is that yes, it will increase the glucose level, but it will not impact the patient in a very negative way. Thank you.
Thank you. That's important. One should emphasize the point as most patients, or there are patients who try and increase the concentration of glucose in the bag, meaning that using the highest concentration to produce more fluid loss. That practice will end up affecting the membrane, peritoneal membrane, and then reducing the lifespan of their peritoneal dialysis treatment. So that's an important aspect. Yes, the concentration of glucose is important. We use it in order to remove more fluid, but one has to be very careful not to abuse it. So I just want to highlight that point. Okay, maybe let's move to the next. Okay, one question by Geraldine Chikania. We do have different levels of healthcare. I presume that primary prevention of CKD should happen at primary level. A primary level. Sorry, I lost that question here.
The question is it happening or is it non-existent in primary healthcare settings?
Yeah, okay.
Do you want me to answer that one?
Go ahead.
Well, thank you very much for the question. I think it does happen. There is some screening, but as I mentioned in the presentation, is that it's not well coordinated and it's not well integrated into looking specifically for CKD. But we don't want to create silos to say we want a specific CKD clinic, specific hypertension or diabetic clinic. Is that the clinician should be aware that in the primary care setting that there's NCDs and that the NCD should be looked at as a whole. But this needs to be coordinated and it has to be algorithmic based. So it does happen, but not to the level that will benefit the majority of the population as yet.
Okay. Let's see, there's one more question here. Let me find. I can't see that they announced one question, but I can't see it in the list here. Let me try a question and answer block. Nishle, did we cover all the questions? It seems that I saw one question that I cannot retrieve. Nishle?
Prof, all the questions have been answered. I think we can wrap up. Thanks.
Okay. All right. I think thank you all for attending to this session. Let me just show you my last slide. See this one. Yeah. This is my last slide, actually my first slide to see that this is an important topic that we have covered. I think we managed to cover the primary prevention by Dr. Aripasad to set the scene, the theme in terms of what can be done in terms of prevention of CKD, chronic kidney disease. As you see from diabetic hypertension, HIV has been covered. And then the secondary prevention by Dr. Adeni to go further to delay progression of CKD in our patients with various strategies that he alluded to. And I try to emphasize that although one may think that when you reach end stage kidney disease, you may not have to prevent, but it's important to prevent death. It's important to prevent complications from hypertension, anemia, and mineral bone disease that may still happen. So it's important that we manage our fluid properly, acid, base, and electrolyte, very important to nutrition, avoid toxin, avoid high potassium diet, and as well as let's make sure that our treatment is managed properly, being dialysis or transplant. It's important that we realize that it's a multidisciplinary team management, and we have to make sure that we have the opportunity to have a nephrologist who is qualified to lead that team, but everyone has a place to pay in this multidisciplinary team and take advantage of all the offerings that may be there. I know sometimes the social and psychological aspects are not well covered, but they play an important role for the well-being of our patients and to prolong their life. And they have to make sure that the patient need to be well looked after. And the patient dialysis is not a terminal patient that you neglect. You need to be well. I remember one of my teachers used to say, if the patient dialysis is so sick, is miserable, there are two possibilities. If it's, don't blame dialysis, don't blame the machine. Either we are not using the machine properly, so we need to go back and try to learn how to use it and how to use it properly with all the expertise that is available, or there's something else that need to be found. Our patient who came because they have infection, they have pyelonephritis, and they are in pain. Everyone blame dialysis. No, we have to make sure that we go back to the drawing board, examine the patient properly. You have to examine the patient well, and to not to rely on the machine. We need to make sure that we take care of our patient holistically. That's what I would like to thank the organizers, thank the University of KwaZulu-Natal for hosting us, for giving us the opportunity to address this important topic. I would like to thank my co-presenter, including Dr. Sudesh Adipasad and Dr. Denis for spending time and preparing these talks, and all the team from UKZN who have been involved, including Lishley. I would like to thank you all for the opportunity. And last but not least, all the participants who followed this presentation and contributed to many questions that make it worthwhile. And last but not least, let's make sure that we learn what we need to learn to prevent the progression of kidney disease and treat our patient with kidney disease well. Thank you, and we can close the meeting.
Thank you, Prof.
Thank you.